X needs at certain ages, and it's abnormal at older ages. So it is important to know this well in order to distinguish pathological development from normal development. But as I said, we'll be discussing the two most main common foot problems in children, which is the pediatric flat foot and the injoint gait. So 97% of the newborns are born with a flexible flat foot. So this is considered normal. It changes during the development, during growth, through the morphological evolution, these rotations and ossifications of the bones, which we'll be discussing later, due to the neuromuscular development during growth, and due to the fact that the ligamentous laxity decreases while growing. If we take a look at the reason why children are born with a flexible flat foot, it is because the talus undergoes a derotation. So the talocalcaneal angle decreases, as you can see on the two pictures on the left. If this doesn't happen and the calcaneus is positioned straight on the forefoot, the forefoot would be in a varus position, as you can see on the third picture from the left. In order to be able to walk, of course, the metatarsals need to reach the ground, so the hind foot pronates to facilitate this. So this derotation is a part of normal development and is the reason why we see in almost all newborns a flexible flat foot. It is important to mention that we are talking about the flexible flat foot, not a rigid one. A rigid flat foot is always pathological. It can occur in children, and it's important to distinguish the flexible flat foot from a rigid one, as the treatment is totally different. One of the easiest tests, there are a few, but one of the easiest tests to do this is the heel rise test, while the child needs to stand on his forefoot while doing the calcaneal must invert, as you see on the right picture. As a flexible flat foot is normal in children, of course, it needs to decrease gradually with age, and this process should be completed around the age of 7. So a flexible flat foot is normal, unless that it's of course a big deviation. So examination and monitoring during this process is very important, because if we see a child with the age of 5, 6 years old with still a very big eversion of the calcaneus, we know that this normal process, this normal evaluation is not going to be finished at the age of 7, so it's not going to be normal. So it's important to monitor because we have tools to treat it, and we'll talk about this a little bit later in the presentation. Now, what factors influence the proper development of the foot and the disappearance of this pes planus? Well, we know that children that are obese have more risk of keeping the flexible flat foot, so overweight is a risk factor. Also, children with a shortened posterior chain, we know that the normal derotation process of that talocalcaneal angle cannot occur properly. Also, in children with hypermobility syndrome, hypotonia or dyspraxia, we see that the flexible flat foot does not disappear. And the last very important one is we know from research that children who start wearing shoes early and who wear shoes frequently will have more chance of the foot not developing normal. So the key message here is that children need to walk barefoot as much as possible, even when they're small outside in the house. It's important that they walk barefoot as much as possible. Another common foot problem in children is the in-toeing gait. Now, an in-toeing gait is a stepping pattern with a negative gait angle, and this gait angle is the angle between the midline of the foot and the line of progression. As you can see in the picture, normally it has to be around 7 degrees. When the foot turns inwards, we speak of an in-toeing pattern. This is considered as a normal variant because not all children have it during their development in comparison to the flexible flat foot, but it is described as normal until the age of 4 and when it's symmetrical. Asymmetrical variations are always described as a red flag in children, so that's very important to keep in mind. When we examine a child with an in-toeing gait, it is very important to find the segment in which a problem is caused. First of all, we look at the knees. If they are internally rotated, we have to examine the hip because probably the problem will be in the hip. If the knees are not internally rotated, we have to search for it in the lower leg or the foot. And in the foot, then we are speaking of a metatarsus adductus. And as the last one in the row, this is less common and it needs to be treated very early in life by orthopedics mostly, so I won't be talking about that, but we'll be discussing the other 3 causes showed here on the slide. Starting with the femoral torsion, this is the angle between the axis through the column femoris and the axis through the femur condyles. This angle is around 30 degrees in small children, but it needs to decrease. It needs to untwist or unwind. And if this detorsion is too little, if the angle stays too big in the child, will show an in-toeing gait. So this is a bony torsional cause of in-toeing. Important to mention as it is important to for the treatment later on. A soft tissue cause of in-toeing is what we call the femoral position, caused by insufficient exrotation mobility, and that can be caused by a muscular problem, capsular or ligamentous problem. We often see this in children who sit in the W position frequently, as you can see on the picture, or children who sleep in a fetal position, so it's very important to correct this in children. It's also more present in children with a neuromotor development disorder. So we can, if you see that in a child, it's also a red flag for further investigation in that area. Another bone cause of in-toeing can be a tibial torsion. Now, here there is no torsion present at birth, but the tibia needs to externally rotate during the growth. We can't measure the tibial torsion except through X-rays, but we can measure the malleolar torsion, which you can see here on the photograph below, which gives us an indication about this torsion, or we can also convert it to a tibial torsion. So again, this is a bony torsional problem which causes in-toeing, and this is part of the normal growth process in children. So monitoring the position of the limb is very important in children to evaluate if the child is developing normally. We do this by clinical and biomechanical examination. We measure the position of the joints, we measure the range of motion of the joints, position in relation to other joints, and very important, by analyzing the gait of children, which gives us a lot of information. And this brings me to the monitoring of the motor development of the child. Mostly the task of physiotherapist and pediatrician, you might think, and I totally agree. But as I said, the gait of children gives us a lot of information. You know that gait is a very complex task for which a good development of neuromotor skills is necessary. Children with a neuromotor development disorder will also often show abnormalities in the gait pattern. So it is a very important task of the podiatrist to recognize these abnormalities as red flags and to refer the patient for further investigations, as still a lot of these conditions stay undiagnosed. And it's important to contribute in this because these conditions affect the child's life immensely. In children with, for example, development coordination disorders or attention deficit disorders, we often see an asymmetrical gait pattern. We see lack of balance, which translates into a shortened swing phase, for example. We see no contralateral arm swing, etc. When we see this during the gait analysis, we must refer the child for further investigation. We also know from research that in children with neuromotor development disorder, the flexible flat foot remains present even after the age of 7. We usually see also a very large deviation, a large eversion of the calcaneus due to hypotony. We also know that these children have a high risk of developing overuse injuries in early life, which also makes it harder for them to participate and join their peers. There is research that states that treatment with a functional orthotic, which we'll be talking about in a few minutes, provides more stability and balance when walking, and therefore makes walking, playing a little bit easier for these children, and will also help them in preventing overuse injuries. So if we see children with a flexible flat foot or an in-toeing gait, or children with symptoms or neuromotor development problems, we can start an orthotic therapy that differs from the treatment we use in adults. For children, we often use the Blake orthotic, which is a functional orthotic that overcorrects the foot. So a foot in valgus is placed in an extreme varus position in the hind foot. This insole can be handmade, starting from a plaster cast or designed starting from a 3D scan of the foot. And this extreme overcorrection will provide more pronation control in the hind foot, but will also activate the peroneus longus muscle, which attaches to the first ray, the forefoot, and will cause flexion, plantar flexion, so it will bring down the first ray, as you see here in this picture. As a child's foot is still adaptive, this will change the structure of the foot and correct the flexible pes planus permanently. So even when the child is grown up, is 18 years old and stops wearing the foot orthosis, this correction will remain. So this is a very good tool for children as we can adapt the foot for the rest of their lives. There is still a big debate on when we should use this orthotic. There is no question for using it in children with a severe pes planus, in children with symptoms with pain, in children with a neuromotor development disorder, as I said earlier, because we know from the research that it brings them more stability, more balance, and also in children with hypermobility syndrome. But what do we do with mild cases of pes planus? You might compare it with braces to correct the position of the teeth in young children. Is it necessary or not? That's an ongoing debate. And the core of this discussion is really the question if these children will develop symptoms in adulthood that are associated with flat feet, like plantar fasciitis, low back pain, patellofemoral pain, etc. We have a tool that can correct it, so why not use it? But that's a big question, and let's look at some studies. In a study about the relationship between the quality of life and foot function in children with a flexible flat feet, it is estimated that 10 to 60% of children with a flexible flat foot will develop symptoms at some point in their lives. 63% of the children are more physically handicapped by their flat foot than children without a flat foot. And the flexible pes planus is associated with several overuse injuries, such as tarsal tunnel syndrome, posterior tibial tendinitis, etc. In another study, and I find this very important, they looked at the quality of life in children with flat feet by using the Oxford Ankle Foot Questionnaire for children which contains questions on the physical capacities, on school, on play, and shoe behavior. This study shows a reduced quality of life in children with a flexible pes planus. Also, the greater the rear foot eversion, the greater the impact on the quality of life. So this is a very important factor to consider, as even important as pain is not always a reliable factor in the decision of treating kids. For the treatment of the in-toeing gait, it depends a little bit on the cause of the problem. If the cause is purely soft tissue related, we normally start with physical therapy. If the cause is a bony, torsional one, then we start off with orthotic therapy from the beginning. And there are times when we do start orthotic therapy for soft tissue problems as well, as physical therapy is not sufficient. For the treatment of in-toeing gaits, we also talked about the why and the when starting with orthotic therapy in children with a pes planus. Well, here in in-toeing, there are also very good reasons to treat because children fall, trip over more often. Children with an in-toeing gait often find it difficult to play sports, and they suffer more often from pain in the lower leg due to overuse. For the treatment of an in-toeing gait, we normally use a rigid insole, and the anterior border runs from the 5th digit until the middle of the first metatarsal head. So in this picture, it actually is a little bit too short, to be honest. This insole works re-educational. So when the child will walk in-toed, the insole will block off normal propulsion. So the child learns to externally rotate the foot. We know from research that this insole can affect the angle of gait between 5 degrees and to 20 degrees. And it can also be combined with the Blake orthotic to treat a pes planus, as it often presents both. So if we go into studies about the in-toeing gait, as I said, we know that it's effective in controlling symptoms in children, in young children. In this study, they did questionnaires. They asked the parents how much the child falls a day, and they know after the intervention, after starting with the insole, that the children did fall less often, which is important. And this is also a study that looked at 48 children treating with an in-toeing plate, and the gait was measured barefoot with shoes and with shoes with functional orthotics. And also they saw an important improvement in the angle of the gait. So a few take-home messages that are important in treating kids is that asymmetrical findings are always a red flag. Pain is never normal in children. Also, growing pains are not normal in children. They're usually another cause. And if children do not like sports or exercise, there is usually an underlying cause, for example, a severe pes planus or a neuromotor development disorder. So therefore, biomechanical examination and gait analysis is important to follow up the development of the foot and the lower body, as we can influence it during growth. Functional orthotics can be used preventionally or curatively to correct the foot and the gait pattern permanently. And that's a big advantage in treating kids, that we really can make a difference in their later life. Thank you for your attention.